Ladies and gentlemen, dear colleagues, I welcome you to the webinar, the spring webinar of the European Federation of Internal Medicine Multimorbidity Working Group, presided by Maximo Bernabeu Vitel from Sevilla. My name is Edouard Battegay, and I'm going to lead through this webinar. I also meet Bernardo Duque Neves, who is in Lisbon, Portugal. Introduced later. I will briefly tell you what we will be doing, Bernardo and me, and also how the webinar is going to work. So Bernardo is going to give a first lecture, then I'm going to give a lecture, and then we'll have a discussion. So all the questions that you may have, please take them into the question part at the, or discussion part at the very end. And we are also helped by Milena Ognjanovic in Belgrade, who helps us with the technique. So if there are any technical problems, please, put it into the chat or somewhere. So without further ado, what we'll do is first Bernardo will give an introduction, healthcare-oriented artificial intelligence, how it's developed and how it can help us. And I will then go more into clinics and talk about differential diagnosis and disease interactions, switching from human to artificial intelligence. Bernardo is an internal medicine physician, a PhD in biomedical engineering with research focused on machine learning methods applied to electronic health recording systems data for unplanned hospital visit prediction. So in other words, he develops to some extent prophecy. He currently leads clinical analytics for value-based health office at Luz Saúde, Portugal's largest private healthcare group, and he teaches health data analysis at Católica Medical School and serves on the Portuguese Medical Association's AI committee. I also briefly introduce myself. My name is Edouard Battegay. I'm working from Basel and Zurich. I'm the former head of the Department of General Internal Medicine at the University Hospital Zurich, also emergency care. I have developed a new initiative, an academic startup called International Center for Multimorbidity and Complexity, where we delve into disease interactions. So without further ado, Bernardo, the microphone is yours.
Thank you so much, Edward, for your kind introduction. I will now share my screen. Okay. So thank you for the opportunity of being here. It's a real great privilege. In the upcoming minutes, I will try to, in some extent, summarize and try to give a realistic perspective of what can actually artificial intelligence can do today and what will likely do in the upcoming future regarding risk stratification and complexity measurement, in particularly for multimorbidity context. So starting to put the clinical problem that will be discussed along all of this session, I come with some recent data from the Paris study. That was a very large study taken in Europe that asked more than 100,000 patients, and that took a very realistic picture of the reality. We know that the vast majority of patients today, of adult patients, live with chronic conditions, many of them with several chronic conditions. More than 70% of the patients take 3 or more medications. And so multimorbidity is now rather the norm than the exception, with a lot of significant impacts for doctors, for the way we deal with clinical care, for patients themselves, for all the burden that this comes along. And of course, this puts a high pressure on healthcare systems, since most of the healthcare systems have not been designed by scratch to deal with this pandemic. So giving a realistic perspective, and this is a possible patient that many of us could deal with with it today. We see a 74-year-old patient named Maria, who is recently widowed. She lives alone. There's nothing about her that is exotic, since she has a median of 5 doctors to deal with many of her conditions. She takes regularly 11 drugs. And like a recent paper described for interviews with similar patients, these patients name themselves as project managers of their own care due to all the burden that dealing with several concurrent conditions puts in patients by themselves. So dealing with AI and starting to think what can AI do for these problems, we can think on AI, first of all, of a new method to represent reality and to represent data. And most of what we talk about when we talk AI is an evolving topic, and when most of the methods of machine learning methods are put in place, they stop to be called about AI. They just become the general norm of what we deal with. But mostly when we talk about AI, we are dealing with methods that allow us to represent data in a new method and to do predictions and to make and generate new data based on the way that data is represented. And like the language models that currently are very popular on the generative AI world, like the language models were built from words to predict the next words and to generate sentences and to generate full-length text. There are increasingly new works that apply the same concepts of representing a patient history into a sequence, the same way that texts are done. And this allows new opportunities of representing patients or representing conditions. And we can start to move from a paradigm where we have been counting conditions for most of the time when we talked about multimorbidity, and we can start to represent patient trajectories and to compare similar patients in many dimensions that wouldn't be allowed so far. So what I'll be talking today is how can we actually measure multimorbidity in different perspectives, leveraging this kind of representations from data. We can think on multimorbidity, on the risk, on the complexity, and also on the coordination that the healthcare system puts around these patients. And I will now travel along these 3 dimensions and what AI can do for us. Starting on risk and on risk prediction, who is going to deteriorate and what part of this risk is modifiable. Actually, when we review the literature regarding multimorbidity and regarding comorbidity indexes, most of the time we are thinking about how can we use the morbidity burden, the number of conditions, the way that we typically measure multimorbidity, how do we use that information to inform us and to predict a risk. When we think about predicting risk, we need to define, of course, what are we trying to predict. Most of the comorbidity indexes today, they allow us to predict in some sort mortality, but we can also use these indexes to predict other relevant outcomes, such as admissions, such as functional decline. And of course, the risk prediction is not static over time. We need to define when are we predicting, when is this prediction made of, in 30 days, in many years. All of these differs, and the different tools we have and the different ways we have to encode morbidity depend on what are we trying to predict and over what horizon. But most of what we should think about what are we prediction and what can we act on? And that's mostly what we should be discussing today. AI, and in particular, the name foundational models, very large models that are trained on sequences of tokens. And these tokens, like I said previously, can be either words or can be either sequences of health events, sequences of health conditions. There are increasingly high number of papers that have been published in the very recent years that build foundational model for electronic health records, and they all do the same. They build tokens around the data that is represented in electronic health records, the very different events, and they try to predict and to simulate future trajectories of health. So this becomes a new way of trying to predict events in the future, trying to predict morbidity, trying to predict health events. And of course, all of this has been showing to improve the typical way we predict events in the future, but this also calls us to very serious problems of being able to interpret and to understand what are the features that are typically taken into account. So when we are dealing with the number of publications that deal with risk models, we need to be very specific about what are we aiming for and what we should measure or not. And typically all the risk certification literature and machine learning literature focus very much on discrimination metrics such as area under the curve. We always need to understand that these kind of metrics are important to understand if a model works or not, but they often don't transfer when they are moved to another context, and this is something we are all familiar with. A model can be developed on a given setting and doesn't work very well on an external context in another setting. And so this is something that might not be straightforward for the engineering field that often deals with silico data. But for the clinical side, it's very important to differentiate between what is developed in one context and what of this context can be translated to other contexts. Another important aspect deals to understand what is actually the positive predictive value of this kind of models, since often we are interested in predicting very rare events, of predicting who will get the deteriorate in a given time. And these are often rare events that may not be well captured in the typical metrics of risk models. Most of all, we also think about calibration that complements the discrimination, is often not very well reported, but very importantly, we should actually understand if we are trying to predict high risk, what kind of this risk is actually modifiable. And several studies show us important lessons in this regard. From one part, when we are aiming to predict admissions and readmissions, and studies that go deep on this topic and trying to understand among all that is predicted of high risk, what are the actually patients where we can start to intervene and you can try to make things happen differently. And the numbers are really small. About only 1/4 of the cases, when experts look into these cases, they actually acknowledge there are features that are modifiable and then can be intervened to allow a different event in the future. So not only predicting a high risk is the same that being able to actually do something and to intervene to improve outcomes. On the same side, we have many examples of this, and these two studies show this very well. A very large study in Wales developed a hospital prediction model that was validated in more than 300,000 patients. And actually, when it was put in place, it raised emergency department admissions and service use. And this put us in perspective that even after building very solid and robust prediction models, it's not often always the case that they can actually help us in practice. So this leads us to an understanding that is, even if we are able to predict the risk of adverse events, when we are dealing with measuring the typical features of a patient, the typical way we describe a patient, like the conditions he has, we are not always measuring what is important for complexity. And complexity is a very broad topic, and I choose to talk about 3 different aspects. From one way, of course, in the multimorbidity context, we can be dealing about interactions, and Edouard will talk about this in the next lecture. But also there are a lot of important domains that are not often discussed and taken into account when we are measuring multimorbidity, that go beyond the conditions that patients have, dimensions that go for socioeconomical, cultural, environment, and behavioral issues, and also the topic of capacity. When we think about what we should measure other than morbidity. These results are from a study that our team performed in Hospital de Luz. We looked at on almost 1 million patients, on almost 10 million visits, and we understood that the way that conditions are encoded is not very is actually more important than the type of conditions that are included, but the predictive power that these allow us to increase predictions is comparatively small when we compare to other features that are typically collected on electronic health records, such as the utilization. And the utilization, the trace record that we have on patients about how often they use healthcare services or not, give us a very important predictive power of future hospital use that is actually complementary and is not redundant about the measurement of multimorbidity. This leads us to the conclusion that when we trying to measure complexity, this of course does not fit in a list of diagnoses, but most of the time we are only measuring what we can actually measure. So when we try to think about what are the drivers that lead to long-term outcomes, we see in studies like the one I'm presenting here that most of the time only 20% of the outcomes are actually traced to clinical care. Most of them are driven by health behaviors and socioeconomic factors that are not typically captured in electronic health records. So we today have a reality where we are mostly measuring the tip of the iceberg, but there are a lot of important things like the patient's reported information, the patient's experience, and also the coordination among clinical teams that can allow us to better capture complexity in a way that hasn't been captured so far. Also to say that when we are talking about complexity, we are also talking about complexity in the perspective of the patient. And this is not typically measured in the healthcare systems. And this is something that we start to think about to actually measure what is the burden of the treatment that we are putting on patients, because most of the time complexity is an imbalance about these two factors. And this leads us to the third dimension that I choose to talk today, which is coordination. When we talk about risk and we talk about complexity, we are mostly talking about what is unique to the patient. When we talk about coordination, we are talking about how are we arranging and managing the healthcare services we are providing for patients, and how are we fitting these kind of services to the patients we have in front of us. And actually, the fragmentation of care is something that is very important, and the Paris studies that I referred initially show us very clearly that most of the patients report a low coordination index and allow levels of coordination and planning among most of the countries. So studies like this show us what actually we can think about when we try to use electronic health record data for measuring how well do we coordinate and how bad we do coordinate and how care can be fragmented. This study in Denmark on more than 5 million patients measured several different indexes of coordination and show what all of us know, which is that when care is fragmented among many providers and with little continuity, it leads to inappropriate medications and of course an increased risk of mortality. So this takes advantage of data that actually exists in healthcare facilities, but it's not often used to measure this kind of indexes. And most of all, it's not used to be proactively used to improve the way we organize care. Another perspective on coordination deals with the appliance of network science. Network science is not a new science, but it's an evolving field that have been increasing the reach in the recent years, mostly after the social network analysis that allow us a large number of data to be analyzed. And the same methods that are applied on social networks can be applied to healthcare data, in particular to understand how well do different providers cooperate and they share patients. And studies like this one show us interesting findings where for the same kind of patients with heart failure and diabetes. Even after adjusting for risk, they understood that when clinical teams and doctors shared a higher number of patients, they actually got better outcomes for patients, translated in fewer admissions and improved outcomes. So this is a type of data that can be increasingly used and analyzed with artificial intelligence methods such as graph neural nets. And this is something that is a big opportunity to study and to evolve, and it's not really be taken seriously by the healthcare systems all over the world. A different aspect deals with process mining. Process mining is very well known in the industry, in economics, and deals with analyzing how processes are delivered and how the logs of these processes are analyzed and show the reality. And this is something very interesting because if we move towards the timeline of the clinical care process, we understand that often even when we map the clinical pathways and we try to understand who does what in which moment, we always intended for pathways that are linearly, but when we go to see the reality, like this study performed in gynecological cancer, we understand that the variation is huge and the number of actually observed clinical pathways is much higher than one anticipated. So these kind of methods and the new methods of representing data can actually inform us about what is the observable pathways that patients take during their care processes. And this, of course, can help us understand, and in contexts like multimorbidity, where several different pathways evolve at the same time, these kind of methods can be very promising to understand this phenomenon. Finally, I must think about and talk about the new concept of agentic AI. Agentic AI is the name that has been popularized to talk about bridging large language models and the sophisticated frontier models to tools that allow actions to be taken in place. And this is a very interesting example of agents that have been developed by Microsoft to actually improve and help doctors in the oncological scenarios to prepare for tumor boards and to reduce significantly the time taken to prepare the meetings and to make the discussion. I believe this is a very good example, still exploratory and not peer-reviewed, but a very good example of what we can expect and apply in the context of multimorbidity, where the consensus and the need to bring several different perspectives to define a common plan can be very hard to implement in clinical practice, and maybe these kind of approaches can help us in the future to put more clearly and more timely proper clinical plans for complex patients. Of course, all of this can be and should be think about the problems that modeling puts us, and this is a very paradigmatic example of a study that allows us to think about equity and bias when we talk about models. And in this study, researchers understood that by trying to predict healthcare utilization, this prediction took into account an implicit bias that was observed, which was the fact that in this population, Black patients actually had lower levels of engagement and utilization of clinical care, and this reflected that for the same level of clinical complexity, the prediction of healthcare utilization in the future was always smaller. So this reminds us of the importance of understanding when we are training models, what is the data distribution that we are dealing with, and when we are applying them for clinical practice, we must always take this into account, since in an extreme, if a patient that cannot access care and it's not used in the model training, it will always be seen as a low risk and low complexity patient or perfectly coordinated, which of course is not true. So these are the message I would really like to take here before we move forward. When we think about AI, we are mostly thinking about representations, about a new way of representing data, and this translating to multimorbidity allow us to think about multimorbidity of not counts of disease, but actually new and more complex ways to represent health, to represent conditions, and especially their temporal evolution. Risk is something that we will always be interested to think about, and we should be very demanding about all the metrics, and we should work closely with the people who develop models to actually have the metrics that matter for us for clinical care. Complexity is a very broad topic, and it's often undercoded in the typical data that we have in electronic health records. But precisely the big leap that we will witness in the upcoming years will be the way that AI is able to represent data and therefore being able to capture many significant features and information that was not captured yet, and that we can start to count on it to actually improve the way that we measure how healthcare is performed. And coordination is often the gap that makes harm, and this can be measurable, like the indexes that already exist, but especially using new types of data that will be captured either in medical encounters, but also and increasingly for patient health records and for personal health records that live outside the clinical facilities. And of course, there is no AI without data. So when we think about deploying and implementing AI tools in clinical care, we should only think about the data that lays down. So I now pass over to Edouard Battegay, that will now talk about how diseases and drugs themselves interact. And thank you for your attention so far.
So Bernardo,
Edouard.
thank you very much. You gave the framework, actually a perfect framework for my talk. And I'm now going to focus in on the patient, and I'm going to show how we stumble into diagnosis and how we deal with disease interactions in multimorbidity. So let me begin first by saying what the learning objectives are, give you an intuitive feeling for decision making by physicians in differential diagnosis and disease interactions, also depending on personality traits. Medical doctors are not robots. In research, they often are considered robots, but they are not. Will artificial intelligence support differential diagnosis and decisions in disease interactions? And I want to create an intuitive understanding. So the first decision we take in any telephone call and seeing a patient first is the question, is it bad and serious, or do we have time? And that is very important, and we usually put it into red, yellow, green. The World Cup in soccer is ongoing. Red, yellow, and green, how we should deal with that. And is it bad and serious? Severe thoracic pain, chest pain, severe abdominal pain, and you already notice what do you mean by severe? Neurological deficits or signs of other organ failure, very high blood pressure, very low blood pressure, very high fever, very low temperature, irregular pulse, very high pulse, very low pulse. And if the patient says he thinks it is bad and serious, or he belongs into a hospital, or when a patient is admitted by ambulance to a hospital or triaged to you by another healthcare professional. And how do we do that? We looked at the University Hospital Zurich emergency unit, how medical doctors do take decisions. And we compiled all the elements that were taken into a decision. And this was an 18-year-old patient with abdominal pain. And you see the age, that was ultimately the differential diagnosis, abdominal pain, flu-like symptoms, etc. Also things that were not there, negative. And you see that in this patient, we had 45 cues, 45 decision elements to make a final diagnosis. That was a prospective study. And on average, there were 7.8 cues. And usually the first 2 or 3 cues were used to do a general impression, and then there was a rule in and rule out heuristics. And strange, this 18-year-old patient with a lower pretest probability of a serious disease had 45 cues, and the elderly patient would have had less cues. Why is that? The less likely a diagnosis, the more complex it becomes, because you have to make sure that you don't overlook something, because
Uh,
he can.
Professor Eduardo, I'm sorry to interrupt you. This is from the technical team. They cannot see your slides. Can you please just share your screen?
I'm sorry. So let me do that. I need to check where that is. We probed that, but I don't see where I can share my screen, quite honestly. Ah, there. I'm sorry about that. So that was, I'm, okay, so let me show that again then. Do you see it now?
Yes, sir.
So that was the 18-year-old patient with the number of Qs, 45. To rule out something. And in this study, there were on average 7.8 Qs, meaning 7.8 information elements, patient history, lab values, radiology, imaging, etc. And the lower the pre-test probability, the lower the likelihood of severe disease, the more Qs we need to rule something out. So how do we do that? This is a map of publications that of the center at the University of Zurich, which I'm a part of, and you see here persons, Mike Martin, Lucienke, a colleague of mine, and also myself somewhere. And you see just publications, co-publications, and you see, for example, Ulrike Ehlert only published with Philipp and here, while others published with a lot of people. Now let's think about symptoms. Sometimes symptoms occur only in context of one problem, but sometimes symptoms occur very frequently. And I'm going to make a test with you. And please think with me. This is a 68-year-old patient. She has severe pain in the shoulder girdle. I let you think associations. She has generalized muscle pain, cue number 2, and she has highly increased blood sedimentation rate and anemia. What made you switch to thinking, oh, it might be something severe? Now, the first question, is it very bad? Outpatient, inpatient, only 3 Qs, 68-year-old patient. Most doctors would say yes, outpatient. Unless, of course, she would say, oh, I don't see with one eye, and you have associations. And think about a diagnosis. Polymyalgia rheumatica. When I do tests, most doctors will say polymyalgia rheumatica. So we have 4 principles of diagnosis. Associations, polymyalgia rheumatica, 3 Qs, boom, quick thinking. Anatomy, where is it? How do we get to a diagnosis? What could it be? Could it be a muscular disease? Could it be something? Pathophysiology, what might be the reason? Whence does the symptom come from? And what is the nosology? What diseases exist? Now let's go to artificial intelligence. That's the prompt that I formulated. I'm an experienced general internist working in Switzerland. A 68-year-old female patient of mine has new muscle pain, especially in her shoulder girdle. The pain is worse after getting up in the morning, blah, blah, blah. She feels weak, tired, kind of feverish, and her blood sedimentation rate is increased, and she has an anemia. And mind you, this is a fault. I wrote a fault. What could she have? Be very precise in the differential diagnosis and also mention rare diagnosis, mention prevalence, sensitivities, specificities, positive predictive values, and especially further workup. No hallucinations. Absolute stringency required. And I did that yesterday afternoon, and I will show you what the result was. So it told me, oh, you made a fault. It's 104 grams per liter, not 10.4. So most likely working diagnosis, polymyalgia, but giant cell arteritis should be somehow looked at. And it told me what to do immediately. And it also told me what are the bases and gave a differential diagnosis. And you see there are other differential diagnoses, including, for example, multiple myeloma. I would not have thought about that. Lyme disease, hypothyroid myopathy, etc., etc. And there comes a workup. But I'm going back because I take up the question that Bernardo asked, is that good or bad later on? But let's do quick thinking again. We admitted a patient with congestive heart failure, hypertensive heart disease, with high blood pressure values, and his NT-proBNP was severely elevated. And he is a former smoker, exacerbated COPD. He was admitted for shortness of breath, respiratory distress. And then we found a pleural effusion, and in the pleural effusion, there were bronchoscarcinoma cells. What did we forget? Depression and anxiety disorder. What's the pre-test probability of anxiety with shortness of breath? That's very near to personality. It's about 80%, or at least depressive mood. Anxiety is almost 100%. So we would have missed that. Let's go further. Let's think, what is the mistake? Anchoring and framing. Ah, we have a disease. That's enough. And we ignore second or third or fourth diseases that may be there. Therefore, we need slow thinking and rules. And here, for example, a Norwegian study. I'm not going into the detail, but they used a large language models to analyze what depressives usually say. I'm worried that, I am anxious that, can you do it quickly because I'm worried? Usually in the medical records, we don't refer to those emotions. So the freely generated word responses analyzed with artificial intelligence were very predictive of depression, anxiety, and worry. Let me go back to human intelligence, to that case. And that's from the book that I'm editing on differential diagnosis. What else did we forget? How likely, for example, in that case with heart failure and carcinoma is a lung embolism? And how likely is a Lambert-Eaton syndrome? That's a not so rare. 10% of the patients with bronchocarcinoma have neuromuscular disease that leads to shortness of breath or contributes to shortness of breath. I would have not have thought about it unless I had a list. Human thinking, slow thinking. How well is our cognitive performance? psychotherapist? Are we sufficiently curating our own database, our human database, Lambert-Eaton syndrome? What happens with the young Google TikTok generation that does not read books and not look at lists? And something that Bernardo also mentioned, there are additional factors and circumstances beyond language that affect our decisions, of which only about 15% are in the National Health System of Great Britain data. And give me an example. And I'm the patient now, and the doctor asks me, "How are you, Edward?" I answer, "Well." The doctor asks me, "How well are you, Eddie?" Well, is that the same answer? In a large language model, without analyzing pitch, without seeing the patient, that would be the same answer. But everybody here realizes that's not the same answer. And intuition tells you something is wrong with Edward in response to the second answer. Another example would be explicit and implicit communication. Let me give you an example. Let's assume there is a passerby, and that passerby asks, "Do you have a watch? Do you have a watch?" The child would answer, "Yes, I'm really proud I have a watch." Explicit meaning. Answer from an adult, "It's 5:35 p.m." Implicit meaning. Answer to a gun-carrying masked person after midnight, "Here you go." The context and setting of that question really does change things. The criminal, the robber wants your watch. That's the context and setting that tells you, if I tell him 5:35, that's not the right answer. Younger doctors tend to understand questions according to explicit meaning. More experienced doctors identify potential implicit meanings, patient worries and fears, including mental health issues. And also, there are different cultures. There are cultures where you are very explicit, where it's legal to be explicit, and there are other cultures, for example, in Japan, where you are high context, you say yes, but you mean no, and everybody from the same culture understands it, but you may not understand it. So there are cultural aspects of that. And then there are two theories how we make decisions. Decision theory says one person makes a decision. And game theory says two persons or more make the decision, and each one does not know what the other thinks. Each one does not know what the other thinks. In other words, it needs coordination between the two persons that are different because all our decisions are game theoretical decisions. And the data, of course, are not cleanly in the system. So we are actually in game theory models. And there is another issue, which is, are you a maximizer? Yes and no. A maximizer is a person that thinks there is a perfect solution. I may not know it. I need to look it up. I need to ask Bernardo. I need to ask Maximo. I need to ask you. I need to ask a neurologist. I need to ask somebody. And a satisfier says, okay, fever, shortness of breath, and he coughs something, maybe a pneumonia, give him an antibiotic, and let's see in 2 days. So the testing aggressiveness of primary care physicians was associated with medical maximizer. and with low acknowledgement of uncertainty in medicine. In other words, can we take uncertainty? Can we accept that? And nurse practitioners and physician assistants don't accept uncertainty. And with urologists or general internists, inappropriate antibiotic treatment for asymptomatic bacteriuria is used more aggressively by maximizers. So personality traits of those that make the decisions, both the patient as well as the medical doctor, has a major relevance. And so the question is AI a maximizer? And that depends on the system that you're using and its curation. Is the data available? And your medical engineering prompt. If I had written with that 68-year-old woman, what could it be? It would have given me a quick answer. That is a satisfier answer, because I told him, be precise, give pretest, probability, give sensitivity, specificities, etc. I made it a maximizer. And you may have to think, should I get a maximizing answer or a satisfying answer now? And usually it doesn't give you an answer concerning triage, because that's a liability issue. For example, if OpenAI ChatGPT told you, no, don't worry about it, make it home care, and the patient dies, it may lead to a legal issue. And that's why usually AI does not answer triage questions, because there are perceptrons in the neuronal net that tell it, don't answer this question. And now I'm coming slowly to the end. Complexity develops supralinearly. Bernardo already talked about this. When we have one problem and then a second problem, and there is a potential interaction in management. For example, somebody bleeds into the brain, but at the same time, he needs anticoagulation for atrial fibrillation. Third problem, and now count the lines. So none, 1, 3, 6, 10, 15. That's a linear, supralinear function. It increases. So multimorbidity is a problem because the possibilities increase supralinearly. And therefore, concerning disease interactions, AI is still mostly very general. You can't use it much in my experience, and also in tests that we run, and also because the complexity is very big, and also because there is very little data. If you look at the scientific literature or the literature for hospitals concerning disease interactions, you have very, very little data. And the spaghetti way of going through the system has also to do with this very little data, where we can lead patients through the system. I summarize. Medical decisions are often associative and impulsive. We use AI for diagnosis and decision support. Even if we Google something, it's Gemini, it's assisted by Google. But we still need books and journals, slow thinking, lists. We need also an architecture in our head. Doctors have been seen as robots in terms of decision making. We do have very little knowledge of personality aspects, maximizer versus satisfier, only 3 studies. Neurologists, are they maximizers? They themselves, I made a test, say yes, but there is no data whatsoever. AI is getting better, but makes many mistakes, often different ones to doctors. The combination of human and AI is the future. And is AI a maximizer or a satisfier? You decide whether that's the case, and the data decide, the availability of data decides whether that's the case. And multimorbidity and disease interactions are literally decisive but very little data. Therefore, AI helps very little in everyday clinical management, except giving an outline of issues to be addressed. Thank you very much. And I apologize for the mistake initially with the lack of my presentation. So we now go to the discussion. Questions to Bernardo and me, not only questions, also comments or criticisms, whatever. Can turn on, sorry, the microphone, or you can write questions into the corresponding part, which is underneath our pictures, the picture of Bernardo and me. All the questions are on Q&A. I have it open. There is only a comment by Maximo Bernabeu Vitel about the session. If not, I will ask Bernardo, perhaps, what do you think about, and that's game theory, what do you think about how one could develop the aspects that I named in your thinking?
Thank you, Edward. And first of all, congratulations for the great talk. I think you really nailed the most critical aspect, which is that we should all demand evidence about all of these tools and the way that we integrate them. And I think the field is moving very fast, and it's difficult to understand what's an expectation of something that can be useful to what is something we can actually use today. And I think as clinicians, we have been used to demand a high level of evidence and guarantee for all the interventions that we provide to our patients. And I think with AI, we should be the same, should not be skeptical. We should try to understand how they work and try them to use and to get a sense of what kind of results do we have, like the demo that you present during this presentation. At the same time, we should all demand for high levels of auditing, of monitoring after deployment, these kind of tools. And I think this is all very new. We are all starting to learn not only how to deal with them, with the tools, but also how to deploy and to monitor them after putting them in use. So this is all very new, and we are all learning about that. Yeah.
So there is one question by Mustafa Sahin. In disease interactions, is proximity important? And I would like to answer that in two ways. One is first socially. Usually the relatives, the daughter, the son, the sister, the brother, lead the patient through the system in a spaghetti-like way because they realize, oh, it needs another doctor also, and is that a problem interacting with my heart disease? For example, somebody has vertigo and at the same time a little bit of heart failure. The cardiologist says, no, the vertigo has nothing to do with the heart failure, but the relatives see that the patient is really suffering from vertigo or dizziness. They go to a neurologist, etc. So that is a kind of proximity. And the proximity of the doctor is also very relevant. Let me give you an example with dizziness. Let's assume you had dizziness now. What would you be unable to do within the next 24 hours? Would you be able to drive the car, the cycle? Would you be able to jump into a shower? or to do sports or whatever. And very often we misunderstand the meaning of things for the patient and his relatives. And that's an important part of proximity. Um, we need proximity so the patient can feel also kindness, which decreases anxiety. And we need proximity to understand this. And I'll go further. If you look, for example, at dizziness, this is a very difficult term that we can not. What do you mean by dizziness? And what effects does it have in your life? And that needs we need to ask questions about what it really is, and that needs proximity and extensive proximity. Yes, I do think, but still, we are experts, and we need to say, we try to be experts. We might also say, I really don't know, I need to look it up. But that's also transcultural aspect. For example, we had in our department patients from Africa, from Nigeria, and when we asked them, what do you think it could be? A usual question in Switzerland. They thought, okay, that guy does not have any clue about this. He doesn't know anything. He even asks me. So there are also transcultural aspects that are very important. And I do think, but the word proximity is a good one. We need that. And I think also AI needs proximity of data. We need to get proximity, for example, when we say, how are you? Well, or well. That's not the same. We need really proximity to emotional expressions. I'm sure that's coming up. Perhaps Bernardo can also comment on that question about, uh, like AI beyond only large language model, including, physiological measures, smartwatches, behavior, entropy of moving, etc.
Yes, of course, I totally agree with you. I think, like I try to convey during the presentation, we should think about AI as opening a new world in terms of what we can use in terms of data and the way that data can be leveraged for things that we never thought they were possible before. So right now, it's really the expectation of being able to measure and to collect data that so far hasn't been possible. And I think even today, if we think about all the instruments and all the risk scores and all of the tools that we commonly use to take decisions, they are still limited by the kind of information that we could measure so far. And we should now start to think about what actually does matter, what kind of features and information and sources of data are likely to be informed, and then try to build and test new ways of measuring and predict what we are aiming to. And of course, typically we have been working in the clinical side with what we have, which is data that we collect during the clinical encounters and the healthcare process. But this is only a very tiny part of the patient's reality of all his life, all his environment, all of his habits. And patients are increasingly using wearables and devices that are able to collect way more data than we are able to think about. And this is all be source material for using these more sophisticated models and new ways of representing and using large amounts of information. So at the moment, this is all a lot of proof of concept and a lot of ways of thinking on what we can do with data, but I believe very soon we can start to test and to deploy and to actually see results of using this dark side, which is very large, of the information that we have been having using before. I totally agree.
Right, and I would like to briefly comment on what you say. Okay, for example, if we look at multimorbidity research, very often there is very little information on how people function. For example, a stroke with aphasia and paresis or paralysis induces depression in 80%. And so how we will be able to measure function, etc., and give it into into the system. It's not only medical doctors, physiotherapists will put variables into the thing that are more about function. And Maximo also asks, to some extent, a political question. He says, how might we incorporate elements of generative and conversational artificial intelligence developed by private companies with their own service located in, for example, Switzerland or Portugal or Spain or wherever? How might we ensure protection of sensitive data, and how might we manage the learning derived from the processing of large-scale data on patients? So, when I put that yesterday on ChatGPT 5.5, a pro system, Bernardo, was I doing a crime?
Well, I don't think you were doing a crime. I think we all this is a very interesting and timely question. Um, I think we all, not only doctors, but I would say the whole society, would there's still a way to go in terms of data literacy and understanding the actual implications of all of this technology. Again, all of this is new. We are all learning how to use it. All the problems that are now arising, they are all new. And there has not been time for all of us as a society to cope with the quick evolution that is taking place. Having said that, this is really a problem because most of the most advanced and most capable models as today are proprietary of a small number of companies that are uniquely positioned to have the computing power and the knowledge to do this. And the gap between these very large companies and all of the others is actually increasing and not decreasing with time, which is a problem. Because in terms of being able to use and to use sensitive data, which is most of what healthcare data is all about. This requires a lot of things. It requires trust about the providers. This requires that we are compliant with all the regulation, and especially in Europe, we are under at least three different legal environments: the AA Act, the European Health Data Space, and of course the general data protecting. And this is something that is still evolving. There are no clear answers, and this is probably the answer why we sometimes have the sense that our own hospitals and organizations are not coping with the most trendy and advanced technology. This is precisely why, because there are dangers in both sides. There are, of course, dangers of not using, because therefore you are making the incentives for people to use on their own devices and do it other way. But there are still, of course, risks and issues when you deploy these in the hospitals. And the making sure that data is not being used for training, making sure that data is not leaving at least the European region, in our case, is important. And this is something that I believe, I'm not an IT expert, but I believe this is today's main concern about the deploying of AI in sensitive areas like healthcare is. So this might explain why we often think that we are not coping with other economic sectors might be using at the moment.
Okay, I will make a short comment on that, and then we will not be able to answer the last question by Mustafa Sain. I'm sorry about that, but my comment is uh, Google knows whether I'm demented or not. Why? Because if I'm demented, I don't find where I live. The entropy of my movements will increase. And it knows whether I have severe heart failure because I walk more slowly. It knows whether I had a stroke. and so on and so forth. So even if we don't put anything into that, and I showed also that analysis by Kjell and colleagues from Norway, a semantic analysis of what you write in a WhatsApp will tell the owners of WhatsApp whether you have depression, anxiety or not. So this data protection to some extent is not possible anymore. And we have to find protection of people in other ways. I'm also worried a lot because if insurances, for example, in the United States, which has not a comprehensive system, gets these data, you might not get an insurance for whatever. And so we need to be very careful and think about how we develop the system, and we need to give it also a legal frame. I think there cannot be any aspect of society that has not a legal, legal regulations without bureaucracy. But I think we need to look at legal aspects as well. So it's 6 o'clock, 5 minutes. And I would like to thank the attendees for their presence, for the questions, the interesting questions in these revolutionary times concerning AI. Thank you especially also to the staff that supported us technically. They are not guilty about my not showing my slides. That was my fault. And I would like to also thank Bernardo and Maximo Bernabeu Vitel for helping us to generate everything. Thanks you very much and bye bye.